Hello, everybody. Dr. Amy here. So I was just on a Q&A. We have weekly Q&As and case reviews with the Focus Elite Access doctors, which, just to clarify any confusion, that's anybody who's taken the certification series, the online learning, which consists of online learning modules and a live training, and then joins the Focus Elite Access community, which is more support. You have the Brain Blossom program that you can use in your office for at-home stuff for your patients, so you don't have to do it at your office. You just do chiropractic and do it well. And case support and marketing stuff and community lectures and all this stuff. And one of the things is we have a monthly case review where the doctors come, submit questions, and we just learn. It could be practical, procedural stuff, office stuff, business stuff, clinical stuff. So we had an awesome one today. But one of the things I thought would be cool to talk about, because I see this question come up a ton, is kids that are afraid to go or having big troubles going to the bathroom in the bathroom on the potty. You can tell I have a little kid because I say potty. And you know, the biggest thing, I'm very systematic, and so I want to help you work through this in a hold apart kind of way. So the first thing is we need to understand that there's a time for clinical tools, there's a time for brain-based tools, and we need to, you're not a hammer and not everything's a nail. So we need to understand, first of all, what are we talking about when a kid is having trouble going potty? So if we have a kid who's having trouble, let's say a 5, 6, 4-year-old, whatever, kid having trouble going poop on the potty, on the toilet, we need to understand, first of all, is that we need to take an appropriate case history. And sorry, someone's messaging me. And we need to be able to say, are we having, pain? Is there constipation? Do they get diarrhea? Is there gastrointestinal issues currently, acutely? So we need to understand that, right? Because, that's usually where we doctors are thinking. We're like, oh, well, they're having trouble because they're chronically constipated. Okay. And then we need to be able to say, okay, what are the tools and the assessment that we bring to the table for a kid who's chronically constipated? Do we treat chronic constipation with, let's say, magnesium? No, we don't treat chronic constipation. We look at the whole system. So we first need to understand, okay, well, we know that as chiropractors, we are working on correcting subluxation. We know that when subluxation is present, that it can either be a result of increased sympathetic activation, or it can be creating or it will be creating, and the snowball effect will be creating this increase or activation of the sympathetic nervous system, and this out of balance or imbalance in the autonomic nervous system. And we also know that there needs to be a clinical exam that's looking for clues. This is a fun part of our job. Clues as to, is a subluxation present? If a subluxation is present and it's altering neurological function, input, processing, output, alteration in sympathetic, parasympathetic, there's going to be some clinical clues. The clinical clue is not a kid is chronically constipated. That's a symptom indicating a problem, not telling you what the problem is. Maybe the kid's eating fruit roll-ups every day all day. Maybe that's why he's chronically constipated. Maybe he's in such stress at school that his system is in sympathetic overdrive and constantly all the time, and he's constipated. We don't know. Constipation is a symptom. It's a sign. It's a window. It's a window into a system that is not operating optimally. What we do is we look for subluxation. If subluxation is there, then we will see alterations in postural, in our posture, in range of motion. We will see alterations and something come up in the nervous system, i.e. neurological compromise. So what are the things you're looking for there? Are you looking at the pupils? That's a really cheap and easy way to look at autonomic balance. We talk about that in the certification series. Maybe you do heart rate variability, highly recommend it. Maybe you do thermography, highly recommend it. Maybe you do SEMG to look at tone and tension, highly recommend it, or some variation of those to have some sort of indicator to look at autonomic nervous system function. So we have to look there, and then we say, hey, there's indicators of subluxation. We know subluxation causes alterations in communication and function within the nervous system. We know that that's really important and critical for the function and processing of an individual, including gut function and health and motility. If we're sympathetically activated, then that impacts motility and just health and the lining of the gut wall, and it can cause a breakdown and dysbiosis and all of this for chronically sympathetically dominant. So we need to correct that. Now let's say we correct, we're working on correcting subluxation. We're seeing all these massive changes. Maybe you do some dietary stuff as well, and we're seeing lovely changes. We no longer have a chronically constipated kid. We don't have pain upon bowel movements. We don't have trouble with frequency of bowel movements. We're doing great. But the kid still won't go potty on the potty. This is where we have to understand we need to know more, not necessarily do more. We don't have a bad kid. We're not necessarily saying we have a bad parent. We need to understand that the parent is going to be frustrated, and you're like, hey, the kid's doing amazing, but he still won't go on the potty. Why do you think that is? This kid's whole life, or at least for some portion of their life, they've had fear, pain, and sympathetic activation around going into the bathroom, sitting on the potty, and having a bowel movement. So even though the problem has been taken away, the actual constipation, the pain, the physiological problem, the behavioral peg of processing is still there. I'm afraid to go on the potty. Logic is not guiding the show here, right? Low brain is guiding the show. I'm not safe in that room, sitting on that thing, going potty. And so we then have to, what we call, play a new game, merge it with reality, and then repeat, PMR. And that is, okay, we've taken away the initial insult. We've improved. We have a more healthy, adapting individual who is not having the symptoms that caused the behavioral issue in the first place, or deflection in the first place. And so now this is an example we used just recently with a kid who's having the same presentation. Mom and dad were like, yeah, he's not on Miralax anymore. He's not having pain. He's able to go multiple times a day. It's normal. It's not diarrhea. So what do? We're so frustrated. We think he's making bad choices and being bad. And we're like, no, he's afraid. So what we did with them is he would ask to put a diaper on because that felt safe to him, and he would go in the corner. So we said, great. Get it. And he was afraid of the little mobile potty as well. So he started going in a trash can outside of the potty, in a trash can, in the squatting position. So he was getting in the squatting position, and he felt safe to do this in a trash can. And we said, don't make a big deal out of it. Encourage him to do this. He's having control and awareness of when he has to go and making a choice to go. And then start doing what we teach. They're called focus stories. They're not just picture stories. It's a little different. It's start doing stories where we take video and do little picture stories of what happens and be silly with it when we go potty. So we start just going when he doesn't have to go potty, going in and saying we sit on the potty, and then we do this silly thing, and then we get this toy. And so we're doing that while simultaneously allowing him to get in the squatting position, have control, and listen to his body cues and that interoception, and go potty in the toilet, in the trash can, in the squatting position. And so then he did that, and then eventually we've given him prediction with the visual stories. We're lowering stress. We've improved physiological reason that he was having the issues in the first place, and he created these routinized behavioral deflections. Now, just watch. It's going to merge, and he's just going to do it. And then one day, he just went to dad and said, I have to go poopy. I want to go in the potty. Will you help me? And we said, don't make a big deal. Just go in, say, yeah, and go in and have him go and help him, and then reward him and do just like what you did in the visual story or the focus story. And they did that, and this kid has been going on the potty ever since. Now, they're going to start him in school. And I said, this is a demand. I want you to know it's possible you may see some pulling in. You may see a little regression with the potty as he becomes sympathetically activated and he has this deflected pattern or routinized pattern from his past. Know that might happen. So again, you're giving parents prediction, And no, we're not going to say, oh no, he's back at square one. We're going to use it as a window into how he's adapting to stress, and we're going to support him, meet him where he is, and make sure he doesn't become deflected and become routinized in that new pattern, but instead use it as a window to understanding where he is and support him through that. So there's a lot of different pieces to this. So when I see questions that are just like, what do I do for this symptom? I love that because you guys are thinking like, okay, great, we understand that we can help, but we have to look at it from a, okay, clinical perspective. What is that symptom telling us, and what are our tools, and how do we assess? What is our assessment? And then how do we continue to assess to know when is it time to bring other clinical tools in addition to chiropractic or brain-based tools in to help that individual function better, engage better, and connect better as a individual and as a family in their environment. And this is everything that Focus is all about. You get to stay in the chiropractic lane, but you get to know a little bit more. You get to upgrade your communication. You become an expert. You provide the help these families need by really coming at this from a hold apart developmental standpoint, knowing what you do, what you don't do, how you support, and seeing their kids for more than just the deficits and challenges. Question here, have you seen if these kids become stressed that they regress with the potty? Yep, that's a great question, and that's exactly, sometimes you will see that. Just like a kid who maybe has a verbal tic, and you see that go away through the same mechanism that we just talked about, and the same clinical thinking, and the same procedures that we teach you to look at, and the same exams, and you're bringing your clinical tools, and you're watching that, and you might see, oh, that sign, that symptom has decreased, that tic, but then they started school, and ooh, the tic came back. Is it, oh no, the tic came back? Or is it, okay, let's sit back and watch and wonder? I always say we have to make sure that we're watching and saying, is this a stop along the way? Because pulling in happens in growth, pulling in and then growth and then pulling in and then growth. That's normal, that's healthy, that's typical development. Or is this more than 2 to 4 weeks and this is becoming a new deflection or a regression of a deflection that we saw before? That's the key. We have to be able to understand development, know a little bit more, lead with the brain to be able to answer those questions. So absolutely, you can see a regression, and the question is it a regression or is it a pulling in? And that's what we have to be able to know. Okay, everybody, hopefully that was super helpful. I'm sure you all have this presentation in your practice because it's a common one. And what we have to offer is pretty incredible. And we know that gut health is so critical to overall health, brain development, processing, and the developmental trajectory. So do good work, learn to lead with the brain, keep it simple, find that simplicity, and help the people in your community that need you.